I want to thank you for joining me this evening. This is a topic that I think is incredibly important and sometimes presents as a difficult means of treating patients that come through our door. October is Breast Cancer Awareness Month, and we thought this would be a good time to talk about breast cancer and the effects of treatment on hair. We see a fair number of women coming in on medications for breast cancer treatment and having hair issues. So, and it also brings up a question about hormones, which is a hot topic, which has changed significantly over the course of my career of over 30 years, as to what's the right thing to do for women postmenopausally. So I'm going to go ahead and start. I'm Dr. Wendell. I am the director of Medi Tresse. So we're going to cover 3 topics, and they're all very interrelated. Breast cancer, just a quick summary about breast cancer statistics, because it is impressive how many women are affected. And then we'll talk about how treatment of breast cancer can affect hair loss and whether or not hormones should be a part of treatment for hair loss, keeping respectful of how it can affect breast cancer risk. Statistically, 1 in 8 women will develop breast cancer in their lifetime. That's 13%. That's a huge number. The numbers increased significantly until the early 2000s, and we'll talk a little bit about that. And then it seemed to have improved. It's estimated that in this year alone, 281,000 women will develop new cases of invasive breast cancer, and about 50,000 will develop non-invasive breast cancer, which is considered precancerous lesions. It's called carcinoma in situ. And again, it's precancerous and felt to increase your risk of developing cancer. Sadly, still about 43,000 women will die this year of breast cancer. Again, a very sad statistic, but 13% is a high number. 1 in 8 women is a lot of women developing breast cancer. Breast cancer is the most common cancer for women in the United States. Of all cancers that women get, about 30% of them are breast cancers in this country. Breast cancer incidence rates were increasing until about 2000. At that point, a huge study called the Women's Health Initiative was published, which suggested there was a direct link between hormone replacement therapy and breast cancer. So we put the brakes on. It was just an overwhelmingly shocking study that came out. Not only talked about the risks of HRT with breast cancer, but also cardiac disease. And it really created a panic in the medical world for those of us that treated primarily women. And I did primary care medicine for 30 years, so I was in the middle of all of that. So we put the brakes on hormone therapy for pretty much everybody at that point, and we didn't know what to do. Gradually, we have come to become a little bit more comfortable with hormone replacement therapy for postmenopausal women, and we'll talk about that a little bit later. It's important to know that 85% of breast cancers occur in women with no family history. And so those of us like myself who have no family history, there's a bit of, we feel somewhat safer, but in fact, the majority of breast cancers are in women with no family history. If you do have breast cancer in your family and it's a first-degree relative, which is a parent, a sibling, or a child, then your risk of developing breast cancer doubles in your lifetime. There are genetic mutations which increase your risk. Many of you know about these, the BRCA1 and BRCA2 genes. On average, 5 to 10% of breast cancers are linked to these mutations. And these women who have these mutations, unfortunately, have about a 70% lifetime risk of developing breast cancer. And these are the women that we tend to see much younger, women in their 20s and 30s developing breast cancer. There's a high likelihood of genetic mutations in that group of women. The other statistic that's important in this discussion is that 75% of all breast cancers are hormone receptor positive, which means that they are stimulated by hormones. They can be either estrogen receptor positive or progesterone receptor positive. So that creates the question mark about hormone replacement therapy if 75% of breast cancers all are sensitive to hormones. The survival rates for women with breast cancer has dramatically improved over the recent decades. And between 1989 and 2017, the overall death rate from breast cancer dropped by 40%. That was huge. A lot of that was as a result of better diagnosis, with mammograms becoming more common, but also treatments were improving. The 5-year survival rate for all breast cancers across all staging is 90%, which is a great statistic. Chemotherapy, the word just creates panic in most of us if we are told we need chemotherapy because of side effects. But chemotherapy in breast cancer improves both the disease-free timeframe as well as overall survival rates. Sadly, hair loss is a side effect of all these types of chemotherapy for breast cancer. And commonly used, these chemotherapeutic agents can cause alopecia. There are two types of chemotherapy. One is non-endocrine or non-hormonally based, and they're listed there. And those pretty much all cause significant alopecia during treatment. Those are the IV therapies that people are familiar with. Then there's endocrine therapy, which is usually recommended after finishing IV chemotherapy. Some of these names will sound familiar: tamoxifen and Astrozole, letrozole. These affect hormones. The tamoxifen literally blocks the effect of estrogen in our body to get to our tissues, including the breast. The aromatase inhibitors block the production of estrogen, which amazingly comes from testosterone. Testosterone turns into estrogen via aromatase, and these medications block that ability. So you actually drop your estrogen levels. So where does the chemotherapy affect the hair? Primarily, it affects the bottom of the hair, which is where the hair cells grow, where new cells are growing. These agents of the initial chemotherapy have a very high frequency of alopecia, many of them causing near total loss of scalp hair or complete alopecia. The hair loss typically begins after the second or third cycle of treatment. And again, if you look at this picture, it affects it at the bottom. In the middle portion, there's an arrow pointing to kind of missing the stem cells, but there's a little pocket of little cells. Those are the cells that are used to make new tissue, and those actually are protected, which is why the alopecia is not permanent. This is the growth cycle of hair. The anagen is the actual growing cycle, and 80 to 90% of hairs on our head are in that growth cycle. And the IV chemotherapy affects the anagen phase, which is why the alopecia is so dramatic and involves so much of the scalp. When 80 to 90% of your hairs are in that phase, and then the chemotherapy affects it, the result, unfortunately, is very dramatic. So this chemotherapy attacks rapidly dividing cells. That's its purpose. It's supposed to attack the cancer cells in the breast, but also it attacks dividing cells in other parts of your body. And that's at the hair matrix, which is at the bottom of the hair follicle. This results in what's called an anagen effluvium. Again, the anagen is that growth cycle. The chemotherapy can also cause breakage at the level of the hair follicle opening. So unfortunately, even the hairs that you don't lose can be very fragile and break off. Again, the chemotherapy usually spares the stem cells that are in the bulb, and that's why alopecia is not permanent. The hair follicle resumes its normal cycling a few weeks after treatment ends, and new growth is usually seen in 3 to 6 months. Interestingly, many of us have heard this, and it's true that the new hair often grows differently. It's a different color, it's curly, it's straight. When it used to be curly, it just looks very different. Eventually, it'll usually become what it used to be, but initially the hair looks very different. These IV chemotherapy agents called taxanes, they can cause prolonged or permanent alopecia. In one study, up to 40% of women had permanent chemotherapy-induced alopecia. Now, that's not the entire scalp being affected, but in most cases, it just means they have incomplete growth rather than complete loss, and the hair remains fragile. So what can be done to prevent the effects of these IV chemotherapeutic agents? I'm going to talk about scalp hypothermia and then some meds that can be helpful or in some cases not. Scalp hypothermia has been used extensively outside of the US for quite some time. It's sad to say that in some cases, the United States lags in certain kinds of treatments, but this is one of them. There are now 2 automated devices that are FDA cleared, and the DigniCap and the Paxman cap are listed. You can see the picture. You literally sit there with this cap on your head, and the cool air, the cool fluid circulates through the cap and maintains a constant, very cold temperature. There are also frozen gel caps which mold to the scalp and need to be replaced throughout treatment. These are not presently FDA regulated. How does it work? Well, it literally constricts the blood vessels in the scalp, which means that less chemotherapy can reach the scalp. The cooling also slows the cell metabolic rate, which means the cells are not going to be in the growing phase as much when the scalp is cold. And as a result, you have decreased uptake of the drug, so it can affect the cells less. The cooling has to stop 30 minutes before the chemotherapy is infused and is maintained for at least 90 minutes after infusion ends. I've actually seen some studies where they leave it going for up to a couple of hours. There was a study in 2015, which was a meta-analysis, which means that they reviewed multiple studies involving thousands of patients. And they concluded that scalp hypothermia was really the only intervention that significantly reduced the risk of chemotherapy-induced alopecia. There were other studies done that demonstrated that the scalp cooling decreased the alopecia by about 50% in about half of the patients using the cap. In most of these studies, they were breast cancer patients. Sadly, these scalp cooling devices are usually not covered by insurance, including Medicare, Medicaid, and most third-party insurance companies, and can cost as much as $3,000. This is ridiculous, but unfortunately, insurance doesn't cover a lot of things that's considered cosmetic. They don't take into consideration the emotional toll that this takes on women. They also, unfortunately, don't cover much of what we do here at Medi Tresse to help stimulate regrowth. It's an argument that I've had with many insurance companies without much luck, I'm afraid. It's definitely worth doing. Unfortunately, a lot of women and families cannot afford this, which is really sad. So what about medications? Can anything help prevent the loss that occurs with chemotherapy? And we'll talk about these medications. Topical bimatoprost, this is a medication called Latisse, which some of you may have heard of, which actually is used to thicken eyebrows and eyelashes, and even in patients without chemotherapy. It has been shown to be beneficial in improving regrowth of eyelashes and eyebrows. It's not been used in preventing it from happening, although we have seen some improvement for scalp regrowth with androgenic alopecia. It has not been tried with scalp regrowth for post-chemotherapy. Topical minoxidil. Minoxidil works by prolonging the anagen or growth phase and also increases follicle size. It has been shown to benefit endocrine therapy-induced alopecia. We use it here for our endocrine therapy alopecia patients. Recent studies utilizing minoxidil in preventing and treating chemotherapy showed that it didn't prevent it, but what it did do is if you use it during chemotherapy, it slowed down the course of the loss. So it didn't happen so rapidly, so aggressively. And then what it also did is it shortened the time to maximal regrowth. So it's definitely worth using during the chemotherapeutic timeframe. Finasteride is a drug that we sometimes use in postmenopausal women with androgenic or female pattern hair loss, but it's not recommended for the treatment of prevention of hair loss in patients with breast cancer because it can increase levels and can cause stimulation of breast tissue to grow. So that is definitely not safe during with patients with chemotherapy for breast cancer. Spironolactone is a medication. It's an anti-hormone medication, which has been used to treat androgenic alopecia. Study shows that there's no increased risk of female breast cancer. And I've also seen some studies which show that it did not increase the risk of recurrence in women who've had breast cancer. There are not any studies available that I could find showing benefit to prevent post-chemotherapy induced hair loss. but it is safe to be used afterwards. So it's something to consider. Endocrine-induced alopecia is hair loss that occurs as a result of endocrine therapy. As we mentioned, endocrine therapy is recommended for women with estrogen and progesterone positive tumors. This treatment takes place as an oral medication. It takes place after finishing chemotherapy. Again, tamoxifen and Astrozole, Letrozole, exemestane. These are medications that may be familiar to many of you. These medications are oral medications taken daily. They're recommended for at least 5 years, and actually under some circumstances, they're recommended longer. What has been found is that these medications can cause a persistent but a slowly progressive hair loss in women who are on long-term endocrine therapy for breast cancer. Studies have demonstrated it occurs in about 30% of the time, but honestly, I think it occurs more, and generally, the medical community does agree that it's probably significantly underreported. These medications block the effect of estrogen on breast tissue. That's what they're supposed to do. And they're very good at it. And they actually do improve it decreases the likelihood of recurrence. And these are medications that are very important for women who have breast cancer, who are hormone positive. The question is, why does it cause hair thinning? And there was a study done in 2010 at the University of Pittsburgh, which showed that as it blocks the estrogen levels, unfortunately, it does increase the testosterone levels. And it's well documented that low estrogen and high testosterone levels may aggravate androgenic alopecia. So it makes sense that it would increase thinning of hair in this circumstance as well. So the treatment of endocrine-induced alopecia, these treatments cause a significant drop in estrogen on the hair follicle, which we know normally estrogen is beneficial for hair follicles. Hair follicles are already weakened by the chemotherapy prior to starting the endocrine therapy. And as that one study showed, it may in fact increase testosterone. So the endocrine-induced alopecia actually mimics what we call androgenic or female pattern hair loss. So we treat it the same. We treat it with Minoxidil 5% daily. We recommend starting it during the chemotherapy timeframe. We utilize low-level laser therapy, which should be initiated immediately at the end of chemotherapy. There are no studies during chemotherapy, but it should be initiated immediately at the end. We do utilize PRP. We use optimal platelet therapy here at Medi, Tresse, and sometimes supplements can be beneficial as well. So in summary, trying to prevent the alopecia in the treatment of breast cancer, we do recommend scalp cooling. We strongly recommend it. It will decrease the amount of hair that is lost. We also recommend Minoxidil 5% applied during chemotherapy. And then once the IV chemotherapy is finished, we recommend low-level laser therapy and PRP as well, which I don't know why it wasn't listed there. Particularly when there's endocrine treatment, which can go on for 5 to 10 years. And then careful diet, including added protein and supplements. After chemotherapy, after multiple rounds of chemotherapy, frequently women are exhausted and their diet may not have been great during that time frame. It's important to try and boost the nutrition after chemotherapy and during chemotherapy as well. Okay, this brings us to the topic of hormones, which is a hot topic. Hormone replacement therapy, as I said, back in around 2002, when the Women's Health Initiative study came out, which was a study of, I think, about 50,000 women, we put a halt to HRT pretty much completely across the board, with a few exceptions. But now, 20 years later, after decades of confusion and contradictory recommendations, we have now come to a place where the medical community believes that hormone replacement therapy, or HRT, can be used safely with very specific guidelines for monitoring and management. It is believed that HRT can be used safely in the management of moderate to severe menopausal symptoms until about the age of 60 or 10 years after the beginning of true menopause. Unfortunately, after 60, the risks of HRT begin to rise. And this is where it gets tricky. Because it does seem to help and actually is beneficial, and I'll talk about that. But past 10 years, the benefits begin to diminish and the risks begin to increase. So who cannot use HRT? Well, if you have a pre-existing cardiovascular risk, and your primary care physician tells you you have an increased risk, you shouldn't be on HRT. If you have a previous history of embolus, clot, or stroke, or acute cardiac disease, you've had a heart attack in the past, you cannot be on HRT. Certainly a history of breast cancer, any positive family history and first-degree relative of breast cancer. Again, sister, mother, daughter, because again, your risk of breast cancer doubles. If you have breast cancer genes, you should not be on HRT. If you have a history of uterine or ovarian cancer, which again are hormonally induced cancers, no HRT. I threw in smoking because smoking increases the risk of embolus for everybody. And if you're going to be on HRT, you really need to be quitting smoking if you're a smoker. And then anybody with liver disease, because these hormones are metabolized in the liver. So HRT, hormone replacement therapy, most of the time you have a combination of estrogen and progesterone. And the reason you need both is because we do know that if you have an intact uterus, if you only take estrogen, you have a significantly increased risk of uterine cancer. So we never give just estrogen to anybody who has an intact uterus. So what are the risks of combination therapy of estrogen and progesterone? There is an increased risk of coronary heart disease. There is an increased risk of invasive breast cancer, stroke, pulmonary embolus, and deep vein clots. However, combined therapy does decrease the risk of colon cancer. It decreases the risk of fractures. It may decrease the risk of lung cancer and diabetes. Interestingly, if you look at all-cause mortality in women who are postmenopausal before the age of 60, women taking HRT have a decrease in their all-cause mortality, which is an interesting statistic. However, again, once a person reaches the age of 60 or 10 years past menopause, these risks become more significant and problematic. Now, if you're only on estrogen, meaning you don't have a uterus, there is still an increased risk of pulmonary embolus, blood clots in the legs, hip fractures. However, this is a fascinating statistic, which has just recently become obvious, is that if you're on only estrogen, there's actually a decreased risk of coronary heart disease, a decreased risk of invasive breast cancer, still a decreased risk of colon cancer, decreased risk of fractures, except the hip, which makes no sense, but that's what the statistic showed. And again, a decreased risk of diabetes. So again, all-cause mortality is improved in this group as well. But again, once you hit the 60 age group or 10 years past menopause, these risks increase so that they outweigh the benefit, and a reassessment needs to be made as to whether it's safe to continue. And these decisions need to be made individually. So this is a quote from UpToDate. UpToDate is it's an online informational, it's an incredible resource for physicians and all medical communities. They review data every week on pretty much every subject. And this is where they stand as of this month. We consider the initiation of hormone replacement therapy to be a safe option for healthy symptomatic women who are within 10 years of menopause or younger than 60, and who do not have any of the contraindications that we mentioned, such as a history of breast cancer, known coronary heart disease, a previous clot or stroke, or active liver disease. So this is a huge change from 2002 when we put the brakes on everybody. We didn't give hormone replacement therapy for over 10 years to practically anybody until more research was done on how could we make this safe. The information from the Women's Health Initiative, interestingly, used hormones of higher dose. They were more synthetic than natural hormones. So when all the information was picked apart and looked at more carefully, we came to realize that there can be benefit, that actually it does decrease the risk of all-cause mortality in women between the ages of 50 and 60. Again, once you eliminate the women who are at high risk to begin with, who should not take it, but there is a place for it. And I think it needs to be considered individually for a woman who's having significant symptomatic menopausal symptoms. It still shouldn't be treated, it shouldn't be given for just any old reason. If someone's suffering from their menopause and they might benefit from HRT, then it needs to be considered, and it can be considered safe if it's managed properly. So in terms of breast cancer, in most studies, the risk of developing breast cancer while on hormone replacement therapy appears to not be increased until about 5 years of use, and then it increases slowly. And then once you get to the 10-year mark, that's when the brakes need to be put on. It's not clear at this point if different forms of estrogen or route of administration, whether it's oral or through the skin, if it makes a difference. There's a lot of controversy about this. And this information that I'm giving is based on a lot of research. Again, it's something that needs to be studied because there is some belief that using it through the skin as opposed to an oral med might have less toxicity. But again, there's more research that needs to be done. The other issue is that using a more natural form of these hormones rather than synthetic may in fact have less risk. And in fact, the type of progesterone is known to make a difference. There are some studies that show that a more natural micronized progesterone may be safer than the synthetic forms. Again, and important to note that during the Women's Health Initiative, which was occurring during the 1980s and 90s and even before, we were using much higher doses of synthetic hormone. There are very limited studies on testosterone, but the risk of breast cancer so far does not appear to be increased with testosterone. Okay, so this brings me to the last part of this discussion, which is if hormones can be safe, should it be considered standard therapy for postmenopausal hair loss? At this point, it's not. And I will tell you that any conference that I go to, hormone replacement therapy is such a hot topic that there's not a lot of discussion about it when it comes to hair loss, but perhaps there should be more discussion about it. This chart shows that the top line is actually testosterone in a woman's lifetime. The bottom line, which is with the circle, the clear circles, is estrogen with a woman's lifetime. So you can see that both hormones sort of peak in the 20s and then gradually decrease. At menopause, the estrogen decreases almost down to zero. Testosterone still hangs around for a while, and that's a problem for hair loss. When we give estrogen replacement therapy, what we find is that the testosterone levels drop as the estrogen levels rise. And we know that this is a much favorable ratio for hair loss. So this is, again, brings some question as to whether hormone replacement therapy might be something to think about for hair loss. So again, the estrogen or the estradiol, which is the most active form, drops 75 to 80% in a woman's lifetime, but the testosterone only drops about 20 to 25%. Therefore, the ratio of testosterone to estrogen increases with age, resulting in less estradiol protection. We know that estrogen is good for hair. Most of us during pregnancy had thick flowing hair that we never had any other time, myself included. Unfortunately, tended to lose it at the end of pregnancy. So we know that these hormones do help hair. Estrogen is good for hair. So what should we think about in terms of hormone replacement therapy for postmenopausal women with female pattern hair loss? One, you should never use testosterone for hair thinning. There have been a couple studies that I've seen where they recommend it. Testosterone has what's called an anabolic effect, which means it can help to stimulate muscle cell growth and can be a strengthening hormone. Unfortunately, these studies were not very well designed and were mostly observational and were based on the opinion of the person getting the hormone. We know from many studies that just asking someone's opinion is not helpful. You need to do hair counts, hair widths. You need to manage the study so that you know that there are some people that are getting the hormone, some that are not. These things were not done for these studies. So I still believe strongly that testosterone should never be part of hormone replacement if a woman is experiencing hair loss. Testosterone pellets, which are actually put under the skin, cause extremely high levels of testosterone in the first month and then slowly decrease. What we see when that happens is oftentimes rapid shedding. The patches or creams don't cause levels as high, but they can still cause some loss. So when we're doing our PRP, which is our optimum platelet count therapy, if a woman's on testosterone supplements, we rarely recommend doing it because we're concerned that they're not going to get the response that we're looking for. If they are on very low dose testosterone and we measure their levels and they're the lower side of normal, sometimes we'll consider it. But women have to understand that the testosterone may affect the benefit of the PRP. So, in summary, hormone replacement therapy, estrogen and progesterone therapy combined, appear to be safe for women until the early 60s. They can be helpful for hair, but only if the labs are checked regularly. The levels need to be appropriate and physiologic and in good balance. Too much progesterone in relation to the estrogen can aggravate hair loss. We know that there are birth control pills and birth control IUDs that are primarily progesterone and have a higher level of progesterone over the estrogen, and these can aggravate hair loss in sensitive people. Not in everybody, but in people that have, I believe, a genetic tendency towards female pattern hair loss. The other thing about hormone replacement therapy is changing the doses frequently can lead to shedding. I see this all the time. And so I think some of the hormone specialists are trying to micromanage these women. And part of it is because they want them on the least amount of hormone to control their symptoms. And I agree with that. But when you're changing the doses every few months, it can cause shedding. That's why even if you put somebody on a hormone that can be beneficial, like a certain kind of birth control, just starting a new hormone can cause shedding. It generally will resolve in a month or two. So, but again, changing these doses frequently can lead to more shedding. So I actually covered a lot of information in a fairly short period of time. And so if you have any questions, you put them in the Q&A section. I'd be happy to answer them. If you have any questions that you think about later and you would like to ask them, you can just go to email us at info@meditrust.com, and I'd be happy to respond to those questions. Right now, I'm not seeing any questions. I know I gave a lot of information. I just want to say that the treatment of breast cancer is life-saving, and I don't want to minimize that. It's absolutely essential, and I know people who have refused chemotherapy because of side effects, including hair loss, and I don't think that's appropriate. But what I will tell you is that the oncologists are becoming more sensitive to the issue of hair loss with women, particularly with breast cancer, because it's so common. And so we're beginning to communicate with them. They're communicating with us. They want to know how to help prevent this from happening and get the growth to come back faster. And so we're working together. And it's something that's important. And I appreciate the oncologists who are now asking those questions. And the cooling caps are important. I wish that they were covered by insurance, but they are not. A lot of what we do here at Tresse is not covered by insurance, but we try our best to make things affordable for people who deserve this kind of treatment. It's important. The other thing that I want to say, and I'll get to this question in a second, is that the women that come in here who are breast cancer survivors, who have gone through the chemotherapy and their hair is fragile and weak as a result of their treatments, they come in feeling guilty. Because I had one woman say to me, everybody says I should be just grateful that I'm alive, that I survived and I'm in remission. But she said, every time I look in the mirror, I'm reminded that I have breast cancer. Even though I'm in remission, I'm reminded because my hair is fragile and thin and I can't do much with it. And I just want to say that that's a very personal thing. Surviving breast cancer is wonderful, and the treatments have improved survivability, and screening has decreased the risk of breast cancer, and that we catch it even before it becomes a cancer, these little lesions that are precancerous, like the carcinoma in situ. These things are important, but you also need to feel good about yourself, and that's a very personal thing. So if someone's struggling because of the treatment that they went through, they should get treatment for it. They shouldn't feel guilty. And so I just wanted to say that we don't judge people that walk through the door here. Everybody has a different level of comfort. And there are some women who have profound hair loss and seem to be okay with that. And that's great. But it's also okay if you don't feel okay about it. And there's a lot that we can do to help people. So I just want to open that door, and I just want to say that. So I'm going to the first question. Someone asked, do you lose eyelashes with chemo as well? Oftentimes you do. They tend to come back. And as I mentioned, the Latisse, which is a prescription, which you can get from any doctor, will help them come back stronger. So when someone undergoes chemotherapy that tends to lose hair, scalp hair, they can also lose eyelashes and eyebrows. It's not always the case, but it can. One other thing here. Well, I think that's the only question. Let me just want to check here. Okay, somebody asked, a woman who's 67, hair thinning on an Astrozole. Again, we treat this just like we treat female pattern hair loss, androgenic alopecia. And because it's a similar problem. It's a hormonal imbalance that is making your hair more fragile and thinning. So we treat with Minoxidil, we treat with laser therapy, we treat with PRP. And so I recommend treatment. It works, it's helpful. And Astrozole just does thin hair. Again, it's not rapid like it does with the IV chemotherapy. It tends to be a slower loss, and it makes the hair a little bit more fragile. But it's important that you stay on your medications, that you stay on the Astrozole as long as your oncologist feels is important. But it's also important to get treatment while you're on it. And there is treatment available. So. All right, I think that's the last question. So I want to thank you all for joining me. Hopefully you've learned something, and I learned actually a lot doing this webinar. But if you have any questions and you think about something later, please email us again at info@meditresse.com. If you have any questions, you can call us, and we'd be happy to answer your questions and be honored to treat you if that's what you'd like. All right, take care, everybody. Thank you for joining us.